So today we're going to talk about the nurse's role with a DKA patient, which is commonly seen. It seems like it comes in waves at the hospital. But first, when you talk about DKA, what does it actually mean? So the D stands for diabetic, and then the K stands for keto, the A for acidosis. So when we break that down, so what is diabetes? Diabetes is so glucose is the main source of energy for the bodies. When the hormone insulin is released from the pancreas, it allows the glucose to go from the bloodstream into the cell. Glucose cannot transport into the cells if a patient is diabetic. If there's too much insulin or not enough insulin, depends on if they are hypoglycemic or hyperglycemic. If there's too much glucose, of course, they're hyperglycemic. If there's not enough, then they're hypoglycemic. Whenever the body uses energy, it tends to use fat and muscle to break down those cells to use for energy. That's what happens when the body goes into starvation mode. Instead of using the sugars that they're allowed to use, they start breaking down other things. So a lot of times when you see a patient come in, you may hear of anorexia, weight loss. You may even see muscle atrophy in areas, and that's all from the breakdown of the muscle cells. So the liver actually is what converts the sugar for patients that are hyperglycemic. So you may have elevated liver enzymes. So when you do your chemistries, these all fall into the diabetic category. For ketones, they're actually an alternative source of energy. They're made in the liver from breakdowns of fats. Excess is eliminated through breath. So you hear of people having like a ketonic breath. It's a very specific smell, kind of like parvo. We know what parvo smells like. Ketone breath is the way that ketones are eliminated, or in urine. So a lot of times if there's a patient that is diabetic or suspected DKA, you will be performing a urinalysis and checking the ketones in the urine. When there are too many ketones, it actually causes changes to the body's pH, which causes a metabolic acidosis. That's where the acidotic part of DKA comes in. It's a metabolic state which causes an imbalance of electrolytes. The main imbalance of electrolytes is phosphorus, potassium, chloride, sodium. A lot of those electrolytes are the main ones that are affected. So a lot of times you'll see patients that are DKA be put on potassium chloride. So being able to do the math of the potassium chloride is important, which we discuss in our math classes. Signs and symptoms of DKA, so they'll come in, they'll have an elevated blood glucose. Sometimes they can be comatose, sometimes they can be lethargic. A lot of times it'll be, vomiting. The patient come in for vomiting, anorexia. They can show increased respiratory rates, weight loss, that muscle wasting we talked about, unkept hair coat. For your cats, they don't tend to groom themselves efficiently whenever they are not feeling well. They can have big key symptom, PUPD, which is polyuria polydipsia, which means they drink a lot of water, so they have to eliminate it. So nursing care, so your part or your role in DKA, questions to ask are what organs are or could be affected with DKA. So we talked about how glucose is, transferred in the liver, breaks down in liver, it goes through the GI system. So the GI system is affected with DKAs. We also have the urinary system. Whenever you have too many ketones, it gets spilled over into urine. So we're checking the urine for ketones. We also have the pancreas. So we're not secreting the insulin sufficiently as it should. So the pancreas is affected. So there's more things involved here than it just being a blood sugar problem. What medications do you expect this patient to be on? So as a nurse, if it's kind of like you're the last person that the patient goes through. So if you notice that the potassium was low and that this patient's not on KCL, it's up to you to go to the doctor and ask, was this patient supposed to be on KCL? Maybe it's not, at least you asked, you found out. That's something that you should be aware of. Gastroprotectants. These patients they're nauseous, they're sick, they don't want to eat. So maybe something to help protect their GI system or make them feel less nauseous. Also insulin. Is this patient hyperglycemic? If so, then an insulin tree is usually made. And that just tells you, when you check the blood glucoses every so often, depending on the value, is how much insulin you give that patient. They can also be placed on an insulin CRI in most critical cases, but for the most part, it'll just be the insulin tree. So what procedures or assays do you anticipate? So we will, of course, run blood chemistries and electrolytes, because as we previously stated, the electrolytes are affected. There are four main electrolytes affected by DKAs. We'll also do CBC. In some cases, they'll do blood gases to confirm that the blood pH is acidotic. We can do the ketone urine strips, urinalysis, CPLIs, because again, the pancreas is affected. So a lot of times you'll have DKAs come in with pancreatitis added onto that. So again, your medications could be pain medications to cover the pain from pancreatitis, because it's very painful. Sometimes they will want to do radiographs or plus or minus ultrasound as well. So what all does that mean for the patient in the ICU? So if you have a patient in the ICU, you realize that they're gonna have PUPD. Remember, the frequent drinking, frequent urination. So that means that you may want to pay attention to the patient if they become a little bit more antsy, if they become vocal, if they seem to be unable to get comfortable in their cage. They may need an extra walk outside. Another symptom we talked about,
The dog sounds like it's walking in this room.
There we go. GI upset. So we want to keep an eye on the feeding. A lot of times they don't want to eat whenever they are in the ICU or in the hospital, because anorexia is one of the side effects. So we may need to take a little coaxing, a little time into feeding, which means we may want to try hand feeding or warming the food or putting a little bit of food in their mouth. So we're trying not to just check the boxes on them. We're actually trying to understand that their disease process is making them not so hungry, and that taking the extra time to feed them and coax them into eating can be beneficial to them. We want to notice the difference between pain and fear. So again, the pancreatitis that the patients can get can be very painful. So we want to be able to distinguish whether the patient's in pain or whether the patient is fearful. Again, we will have a behavioral class, if you're not familiar with that, to tell the different signs. We also have the pain score that the patients you're supposed to assess. There's a chart on the treatment door that you can follow to associate the pain scale. And then you want to notice the patient's behavior. Are they nauseated? So some signs of nausea is drooling. Cats, if you offer some food and they start licking a lot, that can kind of mean that kind of makes them feel a little nauseous. So notice the behavior. If you've been that patient's nurse for a couple of days, then you're probably the best person to tell the doctor when any types of changes happen. You want to check the bedding often. So sometimes those fearful pets will not alert you when they need that extra walk. So every time you check on a patient, you want to make sure that you're putting your hands in the cage and filling the bed as well. A lot of times we have blankets put in the cage, and some of them are a color that, if they urinate on, it can kind of camouflage it. So checking the patients is not checking the boxes. It's actually putting your hands on the patient, putting your hands on their beds, trying to coax them to eat. All of these things go into a good quality nurse understanding the disease processes that they're going through. So for this patient scenario, Jimmy is a 13-year-old male neutered terrier mix. He came in presenting with vomiting, lethargy, anorexia, and weight loss. So when they did chemistry like CBC, they noticed that the blood glucose was 629. He also had elevated liver enzymes, mild leukocytosis with neutrophilia. The CPLI was abnormal. The urinalysis had bacteria, protein, glucose, and ketones present. So all of this is what we talked about. We're just putting it into a case now. So we're actually taking it from paper and putting it into a patient. So we notice that our blood glucose is high. It's at 629. Our chemistry values are elevated. So this kind of tells us that we have some pancreatitis involvement when you combine the chemistries and the CPLI, the abnormal CPLI. So that tells us that we got some pancreatitis on board as well. The urinalysis, when they have too much sugar in their bloodstream, it spills over into the bladder, and that causes a very nice environment for bacteria to grow into the bladder. So a lot of times you will see UTIs in these patients. So this patient has bacteria, has protein, glucose, and ketones. So this is telling us that this is so severe in this patient's blood that it's causing glucose and ketones to be spilled over into the urine to be eliminated. The body's trying to get rid of it because this is toxic stuff when it builds up in the bloodstream. So the body's trying everything it can to get rid of it, but it's also set up a nice warm area of sugary growth for bacteria. So what can we expect to do to this patient? So we're gonna place an IV cath and a sampling line. Why are we gonna place a sampling line? We wanna place the sampling line to save this patient's veins. We're gonna be doing blood glucose checks every 4 to 6 hours, depending on the severity of the case and the doctor. So instead of having to collect blood every 4 hours from this patient around the clock, we're gonna place a sampling line. So knowing this animal's disease process, we know that we need to get an IV catheter in and we need to set up for a sampling line. Also, we know plus or minus the blood work, whether we need a bag of fluids with additives. So to make sure you're on high alert to review the blood work of your patient and to make sure that those orders are carried through. Insulin, we need to see what type of insulin the doctor wants this patient to be on. We need to ask the doctor if they can make an insulin tree for us to follow, have the doctor talk about the plan of the patient. Gastroprotectants, we talked about. Obviously, this patient has a touch of pancreatitis, so we're going to have some type of gastroprotectant, anti-nausea medicine, maybe some pain medicine, maybe some antibiotics because we do have a UTI. The pancreatitis can also cause secondary infections. So knowing all of this disease process, we're putting the pieces together. Anti-nausea, we talked about how this specific patient came in for vomiting and anorexia. So we already know that they don't feel good. So we're gonna put this patient on anti-nausea medications. And analgesia medications, so for the pain of pancreatitis, because again, it's pretty painful, and that we had already said antibiotics. So what are some of the main electrolytes affected with DKA? What did we talk about? Some of the main electrolytes being sodium chloride, which can be replaced with the dehydration or IV fluids. Potassium, a lot of times potassium and magnesium, they go together with being depleted from DKA. And then again, phosphorus is another one, or phosphate. So what does DKA stand for? What did we talk about DKA stood for? It stands for diabetic ketoacidosis. So how does the KCL benefit the patient? So we talked about how the potassium was depleted. We talked about how we want to replace that with diabetic ketoacidosis patients, but why is that important? So this patient, blood pH has become acidotic. KCL actually acts as a buffer. So this can actually help bring the pH back to a normal level within the body. So why would we consider a sampling line? Again, we talked about a sampling line, how this wants to trigger for a patient that comes in as a DKA. We want to trigger to get a sampling line in this patient. You may, if you're don't know how to do it, I highly suggest that you learn how to do it when someone's putting it in. But we want to learn how to do that because of the frequent blood draws. A lot of times it's every 4 to 6 hours around the clock to get these patients. So instead of them getting stuck to save veins, we place a sampling line. And that's all I have for today on DKA.